We start, basically, let me go back a step. This is a presentation that's under the module for abdomen, and it also has some information on peritoneum, muscles, vascular structure. So we'll cover the muscles next week. Don't forget, I'm not here Thursday, right? How could you forget, right? Anyway, all right, we're going to basically look at sections between the xiphoid process and down to iliac crest. We're going to define the abdomen in CT terms. So when we start off, this is an IV contrast CT study. What you have over here from a landmark perspective, you have your liver, of course. We'll talk about this structure right here called the coronoid ligament. Esophagus, we have aorta, not quite abdominal, probably getting close to it. Here's your azygos vein, and then what we didn't see earlier on the chest is hemiazygos. Right off the bat, we have the IVC, and you're going to see it hugging the medial aspect of the liver. So as we work our way down the liver, you're going to see that we have early, not a pacification of the hepatic veins, but what you can see is basically three areas. You have the parenchyma of the liver that's going to be highlighted by the contrast media, but already you're starting to pick up indications of the left, middle, and right hepatic veins, and we know they're going to drain back to IVC. Keep in mind that hepatic veins are always tracked back to IVC. Portal vein will be emanating from the porta hepatis, we'll see here in a moment. Continuing down, we have the beginning of the porta hepatis right over here. We have IVC. We'll talk about this a little bit more later on, called the cruise of the diaphragm and kidney and things like that. But right here you see basically that opening along the medial aspect of the liver called porta hepatis. Yes, ma'am.
I don't think it's available.
Let me go back. That is a bummer. Let me try that again. I thought it was available. Right here, abdomen number part 1.
That looks different.
It does, you know, pop it open. This one right here. Oh, wait. I'm showing you contiguous slices. Hold on. Sorry about that.
That's okay.
You are right. I did not activate it. Here it is right here.
Thank you.
All right, if you refresh your screen, it should pop up now. Very good. All right, give me a second to load it up. Is it the same one? Does it say peritoneal structures and then contiguous slices? So when you open it up, what you're going to find is, if I go back to the beginning of it, you'll see something that looks like this, like the title slide, just like this, and then it has a review of the peritoneums we covered last week. I'm going to kind of forego that right now and get right into contiguous slices.
We're good now.
Oh, okay.
Thank you.
You betcha. Okay, let me pick up where we left off. Again, early sections, put it on slide mode. Here we go. Early sections of the liver, you're seeing the upper portion of it. You can tell that you're still up into the near the chest area. IVC, again, is going to hug the medial side of the liver. You don't quite see it. In fact, let me go back. I think there's one more above it. Nope, not. There's somewhat visibility of hepatic veins. What is happening in the contrast media is going to infiltrate the parenchyma of the liver. And then what you see, not quite opacified yet, is going to be the hepatic veins. You have the left, you have the middle, and then you have the right hepatic veins, all of which are going to point back to IVC. Again, that becomes your mechanism of distinguishing them from portal vein. Once again, the medial aspect of the liver is going to be where you see the porta hepatis. The porta hepatis could be large, it could be small, based on the individual. And you're going to basically see three primary structures within it, which we'll talk about here in a moment, referred to collectively in imaging terms as the hepatic triads. We'll talk about that as we kind of get a little bit farther down. Right now, you're just kind of in the upper portion of the liver. A little bit better definition of the porta hepatis over here. IVC. Structures we're going to talk about during the course of lecture. Here's that little extension of the liver we're going to talk more about called the caudate lobe, found basically anterior to the IVC. here is somewhat of an anomaly. Normally, the right kidney is going to be lower than the left because of the presence of the liver. In this case, we're already seeing the upper pole of the kidney, and we're going to find out later on in lecture. This is a little glimpse of the right adrenal gland, and we'll talk about its characteristics and what it does here in a moment. And typically, you're going to find it directly posterior to the IVC. Continuing down, once again, these are very gradual slices. You have IVC, porta hepatis right over here. And I'm just going to kind of focus right now on the portal system. So as we work our way down, you're going to have, again, this is another portion of the porta hepatis. It extends up in this direction. And early on, you're seeing something emanate from it. That's going to be the left portal vein. Once again, if it comes from the porta hepatis, it's not going to be hepatic veins, but rather portal vein. That is the left portal vein. As you work your way down, you see better opacification of it. The left one's going to appear more superior, typically, than the right. You see early signs of right portal vein. Again, both are coming from the area, although it doesn't look very clear, of the porta hepatis. Here it is right over here. And this one kind of gives you a nice inkling. We'll get into this guy during lecture. This is the first branch of the abdominal aorta, referred to as the celiac artery. It's going to trifurcate, and we'll talk about its branches here in a moment. What you have is basically the common hepatic artery coming through this area, and it's going to be adjacent to portal vein. The portal vein is going to be larger in diameter, and the hepatic artery is going to be smaller, both of which are within the porta hepatis. So what you have is the right portal vein over here, common hepatic artery, space is porta hepatis. Up here, you see a couple things. One, we'll get more into that. The area that shows up, what we think is a fissure, in reality is falciform ligament, which is basically a fatty adipose tissue that's going to connect between the ventral surface of the liver and the abdominal wall. And then right over here, this little line, what's that going to refer to? Any ideas? We talked about it as being the obliterated umbilical vein. Round ligament. So we have the round ligament, referred to in older texts as ligamentum teres. So basically, you have two structures in one area. One is going to be the falciform ligament because of the difference in attenuation. It shows up almost like a fissure, and then adjacent or within it, you're going to have the falciform ligament. Continuing down, at this point, we still have porta hepatis through here, which is the opening. Portal vein, we're getting farther down, so we're seeing the main portal vein over here. Here is the common hepatic artery through here once again. IVC through here. Again, you have a little branch of the celiac artery. Actually getting ready to go into SMA. We'll talk about it. Over here is going to be the falciform ligament. And once again, the round ligament is going to be found basically just underneath the lower edge of the falciform ligament. And then we continue down, and you have a combination of things. We'll get into the pancreas and all of its components today. But what you have directly posterior to the body of the pancreas is going to be splenic vein. When the splenic vein meets the terminal end of the superior mesenteric vein, we call this collectively what? You recall? It's kind of an imaging term where you have the birth of the portal vein. Portal confluence. What you have over here is the portal confluence. So again, that's more of an imaging term. It's where the splenic vein is going to meet up with the SMV. As you go back up, from this perspective, go back up superior, now it becomes portal vein straight up. Go down, portal confluence, and again, you're going to see the splenic vein posterior to the body of the pancreas, and then continue down. What you end up with then from this point is SMA, which was just beginning to emerge, and this becomes SMV. So below this point, you have SMA, SMV. Above it, one level, at least in this one scan, you'll have portal confluence, and then above it, you'll have the actual, let me go back down, or go back up rather, you have the actual portal vein. So here's portal confluence right here. Portal vein, and then as you continue up, then you get into right, left portal vein, And then if you keep on going up, what you'll have going into the IVC will be hepatic veins. So we'll talk a little bit more about that today, but just kind of review where we left off. So again, these slides are going to be available for you, but let me begin by giving you a little bit more detail, some of the structures we're going to encounter in the abdomen. And we've already covered liver to a certain degree, but I want to give you some landmarks that go along with it. All right, part of this is a presentation Leslie had done for another course, so I just kind of took it and made some changes to it. On the liver, we talked about this before, you're going to have that falciform ligament coming straight down, and it's basically a triangular shaped structure that will connect to the abdominal wall, to the diaphragm to a certain degree, and then run along the surface of the liver. Again, because of the difference in attenuation, it's more adipose, so it's going to have less attenuation. It almost appears as a fissure. There is a small depression in this part of the liver, but for the most part, it's just the falciform ligament that appears to be a fissure. On the under lower edge of it, again, you have the obliterated umbilical vein that now is referred to old term ligamentum teres or round ligament. So this is what basically remains from the fetal circulation of the liver. And again, as you have the child born, they cut the umbilical vein, it obliterates or simply becomes more fibrous, and this is what's remaining of it. So it becomes a landmark that we're kind of familiar with. The thing about the falciform ligament in imaging will divide the liver into two major lobes. It's going to be left, which is smaller, and of course the right, that's a lot larger from that standpoint. The coronary ligament, kind of running off in this direction like this, and to a smaller degree over here, is going to attach between the ventral surface of the liver and the diaphragm, and sometimes it'll opacify. So if you ever see something that kind of runs in this direction, especially for CT scans, you'll get a little glimpse of that coronary ligament. Flip it around, just so that you kind of get a feel for what you're looking at. The porta habit is kind of a confusing image right over here. You're going to have these structures going through it. Here's the round ligament. But over here is going to be the IVC. And the lobe that appears to be almost like a tail, it's going to, if you flip it back around, it'll be anterior to the IVC, will be the caudate lobe. So it kind of extends more medial, and you're able to pick it up quite readily. The one area that has been debated, I'm not sure if it's on the slide, I don't see it, is the quadrate lobe. The quadrate lobe is kind of in another area of the liver. It's been pretty much eliminated from most textbooks, but some imaging people still refer to it from that standpoint. Okay. Again, porta hepatis is the opening along the medial aspect of the liver. What I won't get into is the segments. I think in more advanced classes you might need that information. The point I want to make is that here's your IVC, and what you're going to have is two major channels of hepatic veins draining back into IVC. So you have the middle, you're going to have the right, and you're going to have the left. So basically these three tributaries will be carrying venous blood once it's been filtered back into IVC. And again, that becomes your landmark to distinguish the hepatic veins from portal vein. Questions on that? Different coronal perspective over here. Again, you have portal vein coming in. Here's your porta hepatis. Here's one major, probably the middle hepatic vein, and your IVC coming up from this perspective. Just gives you a little bit different angle from it. Blissen's capsule, let me make sure I mention that. Basically, it's a fibrous capsule that's going to surround, or a tissue that surrounds the liver. Not significant from a landmark perspective. The only area it doesn't really cover is going to be where the porta hepatis is. It just happens to be a feature, not so much a landmark. Ligaments, we've talked about these before. Ligamentum venosum is going to be found down here toward the IVC. Again, with fetal circulation, blood is going to come in from the umbilical vein. It will be skirted around or shunted away from the liver, carried into a structure called the ductus arteriosus, and then directly dumped into the IVC. So the liver doesn't become functional for the fetus until birth. Falciform ligament is, again, the obliterated umbilical vein. No, I'm sorry, not falciform ligament. The round ligament becomes the obliterated umbilical vein, coronary ligament was that little structure that basically is found along the ventral aspect of the liver and the diaphragm. Fissures, the one that we're going to focus on primarily is going to be the porta hepatis over here, because within it we're going to have the hepatic triad. We'll talk about that next. The other fissures are not significant from a landmark perspective. What you see over here, again, porta hepatis on this different scan, and anything that you see within it has to be one of the three triad. Portal vein, common hepatic artery, and what's the third one? Do you recall? Not a vessel, a duct. Common bile duct. We have riveting lecture. Okay, good. Common bile duct. Way to be, guys. Okay. Over here is going to be the falciform ligament over here, which has a different attenuation. And then within it is going to be, given the scan, the round ligament or ligamentum teres. Porta hepatis, we talked about it before many times already. Basically, what you want to keep in mind is what we call, this is an imaging concept, the hepatic triad. It basically tells us that if something's going to be seen within the porta hepatis, it's going to be one of these three. It would be portal vein, common hepatic artery, or CVD. So in imaging perspectives, it helps us distinguish these structures from others that may be found in the liver. So again, you're not going to see this in A&P books. It's more of an imaging concept. So those three would be what we find in the porta hepatis, therefore we call them hepatic triad. Here's a different reconstruction perspective. Again, it's kind of giving you the liver back over here. We have the portal vein come in. Actually, what you have is the SMV coming up, bless you. You have over here IMV, which we don't pick up on many of the scans because it's small, it's variable. But it basically will go into the splenic vein, which again is going to be found posterior to the body of the pancreas. When the SMV meets up with the splenic vein, we have the portal confluence that's being formed, and then from this point forward or going up, we have now portal vein. Once it goes into porta hepatis, you're going to have the left and the right portal vein emerging from the porta hepatis. What you really can appreciate is that the SMV is going to basically collect blood from one half of the large intestine and the majority of the small intestine. So when you get any kind of thrombus formation in this area, patients don't do well. They end up with necrotic bowel from that type of blockage. So it really becomes a primary vessel and one that you have to evaluate carefully in terms of doing an abdomen scan. Once again, we saw it earlier, portal vein, hepatic vein, IVC, which then is going to be where the hepatic veins drain into, and just a different perspective from a coronal. Hepatic artery is quite small. It's going to be basically one of the three branches of the celiac artery. It's smaller in diameter between it and the portal vein. It only basically provides 25% of the oxygen needed by the liver. 75% is provided by the portal vein. So the reason for that is that the portal vein still has a lot of residual oxygen within its venous collection. So it able to sustain the liver. The hepatic artery quite small, and only 25% of the arterial blood that needs to sustain it is going to be in that area. Over here we have an MR. We have basically the celiac artery coming off this way, common hepatic artery coming off this way. There's three branches of the celiac. They're going to be namely common hepatic artery, left gastric, sometimes referred to as gastroduodenal, and the splenic artery. So those three make up celiac triad, again, common hepatic, splenic, and then left gastric. And that's going to be the first branch below the diaphragm of the abdominal aorta. So you see it somewhat in that perspective. Venous flow, we've already looked at the hepatic veins going through the liver. Gallbladder. We're not going to do a lot with gallbladder. I think you most of it had it in other imaging classes. Certainly the ultrasound students do a lot with gallbladder. It's found in the anterior inferior margin of the liver. We know it's going to store bile until fat is detected in the GI tract. Then cholecystokinin, the hormone, is going to be released, causing contraction of it. So based on the modality that you're working with, you may do some gallbladders. In most cases, there's other systems such as ultrasound that are far better for that. One thing to point out is that you're going to have a small cystic duct right over here. It's going to have some valves within it that help control any kind of small debris or stones from entering into the common bile duct. You're going to have the right and left hepatic arteries coming down and forming the common bile duct or CBD from this point down. In most cases, what happens, it's going to join up with the main pancreatic duct, and they're going to combine and then go right through what was called the ampulla vader, now it's called the hepatopancreatic ampulla, and actually through the sphincter itself, so it goes right into the GI tract. So in most cases, when you cannulate this area, you're going to end up with contrast going through both hepatic artery or pancreatic duct along with the CBD. So this air becomes important from that perspective. Valves of Heiser basically are nothing more than small mucosal folds that help cut down that debris we talked about from going into the common bile duct. It's kind of a last gap defense from stones entering that area. And then again, here's just a different perspective of the gallbladder, the GI tract, things like that. Once again, common bile duct coming down, your gallbladder is back over here, possibly a little bit of the cystic duct coming in from this direction, coming down. Here's your main pancreatic duct, which used to be called the duct of Wirsung. Now it's called main pancreatic duct. Typically, they'll combine and go into the GI tract, which is the duodenum right over here. That will deposit both bile and pancreatic enzymes. On some cases, you'll have two openings that go into the duodenum. So it goes in through a separate ampulla and a sphincter. Not always, but oftentimes. Gallbladder we see on imaging, again, located on the anterior lower margin of the liver. Pretty easy to pick up and pretty consistent landmark. Questions on that? Kind of a brief overview of abdominal organs and where to look for them. All right, let me open up a second present. I want to cover, if I can get to it. It's not open. Into a couple more major landmarks. We're going to talk about the abdomen. Then we'll begin to pull it together in regard to sectional landmarks. The one of significance right off the bat, and you have this presentation. Is it okay? Good. This basically the main structure we're going to talk about right off the bat is going to be the pancreas. The pancreas is an important structure. It's certainly prone to neoplasms, cancers, things like that. It's kind of an unusual structure. First of all, it's going to be within the retroperitoneum, located in the anterior perirenal compartment. It's going to have 5 components that we're going to lay out for you. It's going to basically start off in the hilum of the spleen, run somewhat diagonal, and eventually the head of the pancreas is going to be adjacent to the duodenum, forming that C-loop process. It is an important structure. It produces digestive enzymes. It produces insulin, things like that. So it's really a critical structure. And we'll see a lot of it as we begin our abdominal structures landmark review. Here it is over here on this one image, and what you have is kind of the pancreas coming up this way and over. It doesn't really give you the full flavor of it. Here's going to be your spleen out here. This is where the tail's going to be. And you have 5 distinct components of the pancreas. You're going to have the tail. Let me start off with the way it's listed here. You're going to have the head, and the head of the pancreas is going to be adjacent to the duodenum that helps form that C-loop. So you're going to have this area right through here. We'll show a better example of it here in a moment. And then what's listed as UP is a small finger-like projection of tissue, which is also pancreas, called the uncinate process. Basically, it's going to be found adjacent to the SMV, and we'll look at examples of it. Then going back toward the tail, you're going to have the neck of it, which is this constricted area right over here. Continuing down, you're going to have the body through here. And again, the body is going to become an important landmark for identifying the location of the splenic vein. And then the tail of the pancreas will be located in the hilum of the spleen. So you have 5 components. You have tail, you got body, neck, head, and then finally uncinate process. So you're able to see all 5 of these structures as you work your way down. Here it is over here, the pancreas from a different perspective. Once again, this main pancreatic duct, referred to at one point called the duct of Wirsung, basically is going to run near the length of the pancreas. Here's the head of it over here. And then, hard to distinguish on sectional imaging, you're going to have the C-loop of the duodenum right adjacent to the head itself. This is one of the reasons why patients who develop pancreatic cancers, oftentimes in the head area, they will produce an obstruction of the GI tract as well. That little extension of tissue back over here is going to be the uncinate process, and then as you work your way back, the neck, and eventually down toward the body and tail. So it basically is going to have what we call a mixed attenuation appearance. Gives you a little different appearance from other tissues. It has, again, some connective tissue in it, a lot of glandular tissue, and you get somewhat of a smattering of different structures as it works its way down. Again, the pancreas is going to be retroperitoneal in the anterior perirenal space. Compared to the spleen is going to be intraperitoneal in the left upper quadrant. It has a very distinctive appearance about it. It has the hilum that gives it a crescent type of perspective. Pretty easy to identify. In fact, we use the spleen to help us identify the tail of the pancreas that's within it. Basically, it is kind of debated in terms of what classification it has. Some will say it is a vascular component, others will say it's part of the digestive system. That's kind of little functions of both from that standpoint. Large based on the individual. It has the largest collection of lymphatic tissue and most frequently injured. And the reason for it is that you don't have a lot of protective bony structures around it. It's kind of in the upper left quadrant when patients are involved with blunt trauma to the abdomen. Because of its rich blood collection, oftentimes it'll hemorrhage. So again, it's the most frequently injured organ in the body. We can live without the spleen, but other parts of the body like the bone marrow and things like that have to kind of compensate for a certain degree of what it does. Again, they're going to be basically variable in size. You're going to have 2 components of it, which you can kind of pick up on this one image. You're going to have what we call the red pulp of it right over here, which is going to contain a large quantity of red blood vessels. Basically what the spleen is going to do is going to reprocess, for lack of, the word destroy is kind of odd, but it's going to reprocess red blood cells. So as they become expended, it's going to essentially help with the depleted RBCs. It will filter blood for different agents like microorganisms and antigens. And again, that's what's going to be found within the red pulp. The white pulp basically is lymphatic tissue or lymphoid tissue, and it's going to help store T cells, which help us with our immunity. So the spleen, when you lose it, you're going to have that ability to process depleted RBCs and also for the storage of T cells, which help us with the immunity. So different body systems have to kick in if the spleen is damaged to a point where they have to remove it. It's kind of the last resort. You really don't want to remove it unless you absolutely have to. Questions on the spleen? Kind of shooting through the stuff. Adrenals are interesting. These are small glandular tissues, and oftentimes when we learn about them, we kind of assume that they're going to be found on the upper pole of the kidney. And the reason for that is that we refer to them as suprarenal or supraadrenal glands. So we think they're directly connected to the upper pole of the kidney, and that's a misnomer. Basically, there's going to be a fibrous capsule around the kidney. There's going to be a certain amount of adipose around it. Then you find the adrenal gland. Their locations will vary between the left and right. They're somewhat triangular shaped, but when we look at them on sectional imaging, on the axial perspective, they kind of have that, I keep on using inverted Y kind of appearance. You can kind of see it over here. It has 2 components, the cortex and the medullary portion of it. They're important for producing things like norepinephrine and other corticosteroid type of agents. The adrenals will help us with what we call the 3 S's. They help regulate things like sugar, salt, and sex drive. Yes, sex drive. So the 3 S's. There's going to be a kidney, as we talked about right over here. There's going to be an adrenal gland, and then you don't quite see it. I think an ultrasound you have a better chance of picking it up. There's a fascia called the renal fascia. We used to call it the Gerota's fascia. So what it does basically, if you ever looked at a kidney on a cadaver, there's a tremendous amount of fat that surrounds it. And then if you were to dissect it, you'll get into the adrenal gland. And then there's this little protective fascia that comes up and around somewhat in an oblique manner. That's going to be Gerota's fascia. It's kind of the last defense that separates the kidneys from the other structures within the abdominal cavity. It's fibrous, and it can't show up on imaging. And again, if a patient had a condition like a renal cyst or renal infection that broke out, this Gerota's fascia oftentimes will be imaged, and you'll be able to see a collection or an abscess near it. But Gerota's fascia, again, is going to be the last mechanism to keep any infection from the kidneys from spreading into other abdominal structures. The adrenals, as I mentioned before, we kind of expect them to be attached to the upper pole of the kidneys. This one over here is going to be the left, and we have the right over here. The left, what you're going to find is that it's going to be found posterior to the pancreas, anterior to the upper pole of the kidney, and somewhat medial. So when you look for the left one, it's going to be slightly separated from the upper pole of the kidney and displaced more medial from that perspective. The right adrenal gland, one of the landmarks you look for is the IVC, and it's going to be directly posterior to it. So you're going to have the upper pole of the kidney right over here. You're going to have the IVC, and if you pick up a little whisper of a Y or V sign, that will become your right adrenal. We'll look at examples of both on a coronal and transverse. We'll get into muscles later on, probably on Tuesday of next week, but we talked about a little bit about the cruise of the diaphragm. The cruise of the diaphragm basically starts off as what we call the central tendon of the diaphragm, and then they converge and they produce these fibrous tissues right over here, and they look continuous, and to a certain degree they are, but what you have is a right and left cruise, and what they're going to do is attach to different portions of the diaphragm along the inferior wall, and then eventually right around L2 they're going to insert into the vertebrae, and after they disappear, the psoas muscles will appear. So these guys over here are going to be anchored down. You'll see them kind of wrapping around the abdominal aorta. Over here on this coronal, what you have is the right kidney over here. Just a whisper of the right adrenal gland. Again, notice you're not directly connected to the upper pole of the kidney. Left, once again, a little separation between the kidney and the adrenal, which has that inverted Y sign, and it's going to be found somewhat medial and posterior to the pancreas and to a certain degree the spleen from that perspective. Very small, but very important and pretty easy to pick up once you know what to look for in these guys. Here's another perspective. Once again, a little bit more generous on this MR. You have the IVC over here, the right, rather generous inverted Y sign. Left over here, somewhat medial, maybe not as apparent, would be the left adrenal gland. Here's my pancreas right through here. So again, directly posterior to the pancreas would be the left adrenal gland. Here is the right one we talked about before, right over here. The left one, somewhat diffused right in this area. What they'll say in imaging is that you form a triangle between the upper pole of the kidney, the pancreas, the tail of it, and the aorta. And this kind of area you expect to find the left adrenal gland. So that little triangle helps us kind of get a range of where to expect it. The right one's much easier to find. Once again, more adrenal glands. We talked about a little bit easier to pick up on this example over here. And then the kidney. The kidneys themselves are pretty easy to identify. We're going to talk about the right and the left. We're going to talk about a couple of components of it in terms of the collecting system versus the nephron. But what you have, as I mentioned before, you have a tremendous amount of fat that surrounds the kidney, which helps make it somewhat of an easy landmark to pick up. You're going to have the upper pole, lower pole of the kidney. What we call the renal sinus is where you have the renal pelvis and a large amount of adipose tissue in this area right through here. But what surrounds it is going to be a lot of fat through here that helps give it protection. You're going to have that gyrotis fascia, this little line that runs oblique like this. And then you're going to have what we call the perirenal region, or perirenal fat rather, that again gives it a little bit more protection from that perspective. So you have the perirenal fat, gyrotis fascia, and then the perirenal area. As we look at the kidney itself, you're going to have the outer portion over here, which is pretty dense, and then the inner part that's going to be the renal pelvis right through here. This is where your collecting system is going to be located in the form of calyces, renal pelvis. Out here is going to be where you have the nephrons, which actually produce the filtration of the kidney. So the less dense area is going to be the renal pelvis. And that's kind of what you're picking up over here. You have a vertical pocket. As they say, again, the renal pelvis would be in this portion along the medial wall of the kidneys. And from there emanates the renal pelvis and the proximal ureter. So you see with contrast media, you're able to pick up the renal pelvis going into the calyces or coming out of the calyces. Keep in mind that the cortex itself is where you have the nephrons, which is the functional unit of the kidney that produces the filtration. And then the medullary portion is where you have your calyces, renal pelvises, and the beginning of the ureters that begin to come out from this area right through here. Here's your psoas muscles down here, and we'll look at cruise here in a little bit. Questions on that? Is this kind of familiar? You've heard it before? Your calyces basically are the collecting systems of the kidney. As you work your way through it, you'll see elements of it that are kind of smattered through here based on whether you use contrast media or not. You see them from this perspective down here. You'll see them obliquely, somewhere in the neighborhood of a 20 to 30 degree angle. You're going to have abdominal aorta. You'll have IVC. We'll get into renal veins and renal arteries. Over here is the renal pelvis over here. And eventually, going farther down toward the pelvis, you're going to find the ureters. The ureters are going to run posterior, somewhat anterior, as they work their way from the kidneys themselves. They're going to come up and over the pelvis, called the pelvic brim, which is along the iliac crest area, and eventually they're going to drop into the bladder, which we'll look at later on as we move into the pelvis. The ureters themselves, as you work your way through, what you have over here are the two large psoas muscles. And one of the landmarks you want to look for is that these contrast filled, sometimes even without contrast, round densities are going to be the ureter. So the landmark we look for on these is that the ureters are sitting on top of the kidneys. So you have, the psoas muscles. So you see the little dots right over here. And again, on this reconstruction, you see where they leave the kidney, they come up, which you can't really appreciate. They come over this area called the pelvic brim, and then eventually they drop into the posterior lateral aspect of the bladder. When we look at stones, when you're doing scans, CT scans, there are three areas to consider. One is going to be the UPJ, or uretopelvic junction. This is where stones can get caught up as they move from renal pelvis down into the first portion of the ureter. As you move posterior, again, these are in the perirenal compartment of the retroperitoneum. But as the ureters come up and over this area called the pelvic brim, because of gravity, stones oftentimes can appear or be lodged in this area over here. And then finally, as they begin to move toward the bladder, that uretopelvic or uretovesical junction, or UVJ, is the third area of constriction where stones can hang up. So when you're doing CT scans, these three areas become important in terms of looking signs of stones. 3 points of constriction. Okay. Finally, stomach, which is an intraperitoneal structure, has three components. As we scan from top to bottom, what you're going to find is that the fundus is the most superior posterior portion of the stomach. So as we leave the diaphragm, oftentimes you'll get an air-filled or gas-filled fundus. As you begin to scan down, the stomach will begin to turn anterior and more horizontal. That will represent the body. And then eventually, as it goes and meets up with the duodenum, you have the pylorus. So you'll have three portions you can pick up: the fundus, the body as it wraps around anterior, and then the duodenum will meet up with it and form the duodenal bulb and continue down from that perspective. Keep in mind, this is an intraperitoneal structure, but the duodenum, the portion that is the C-loop, or what we call the descending portion of the duodenum, which is adjacent to the pancreas, is retroperitoneal. So the upper portion, the superior aspect of the duodenum, is intraperitoneal. The vertical or descending, and the horizontal to a certain degree is retroperitoneal, and then where it meets up with the jejunum begins to go back into the intraperitoneal area. So we have three components of the stomach. So you see the body of it over here. You have the fundus up here on this coronal. Up here, when you're first scanning, near the area of the liver, you'll pick up the fundus, and then as it wraps up a little bit more anterior, you then transition into the body. Here's my bulb over here, pylorus. We'll see it a little bit more distinctly as we begin our review of landmarks. Okay, we won't get into a lot of small intestine, but there's certain characteristics you want to look for when we look at sectional landmarks. One of them certainly is going to be size. The small intestine is going to be smaller in diameter than the large. The jejunum is going to have a very busy kind of contour to it. It's because it has a lot of mucosal folds. But what you're going to pick up is as you go from the bulb, you're going to have it wrap, the duodenum wrap around the head of the pancreas, the C-loop. And sometimes it's hard to distinguish on a sectional image between the head of the pancreas and the C-loop. Then it kind of goes into the horizontal portion up here, and then it dips up. Where it dimples off, oftentimes will be in a landmark. And what you find is that this used to be called a ligament of Treitz. Now it's called the suspensory ligament of the duodenum. And this basically marks the transition between duodenum and jejunum, which continues from this point up. So you have that point of transition. And because of this ligament, it kind of creates a dimpling effect. So as you're going across the horizontal portion, it dimples off over here, gets narrowed, and then it continues into jejunum. So that little dimpling effect will become important for you to pick up that landmark. Sometimes along this area right through here where they come together, you'll see the signs of the IMV, of the inferior mesenteric vein. The large intestine, again, is going to be different in size. Its characteristics basically are going to be these haustral markings. These sacculations, they're going to be basically formed by what we call the Tenay coli, which is this large ligament that runs across the length of it. And you'll get these small, or not small, large areas or sac-like structures, which are typical of a normal large intestine. The haustra will give away these versus the small intestine, which will be kind of scattered throughout. Keep in mind a couple things. One is the appendix now in Gray's Anatomy is called the vermiform appendix, a small point. The cecum will match up or meet up with the terminal ileum. You can actually pick that up as a landmark. But from a standpoint of the retroperitoneum versus intra, cecum is intra, ascending retro, transverse colon intra, descending colon, you see where a little pattern here, becomes retro, where the C-loop is right up here this way, is the sigmoid, that becomes intra, and then the rectum, to a certain degree, becomes retroperitoneal. So the large intestine really is complex in terms of its alignment. It's always interlaced through the the peritoneum. So it kind of goes in between intraperitoneal and retroperitoneal. So kind of an interesting structure from that end. Questions on that? Just to give you a little background of the anatomy. Again, this gives you different signs. Small intestine based on the fact that you use contrast as a CT, and then you could pretty much pick up the large intestine based on the air collections and the size or appearance of those haustra along the periphery of the abdomen going into the rectum down here. So we'll be able to pick those up pretty readily from that perspective. More large intestine, again, characteristics of the large intestine going on down. Let me talk about one thing before I leave it alone. Epiloic appendages. we don't have the benefit of a cadaver, but what you have is little fatty little collections along the periphery of the large intestine. Quick story, I had worked with some anatomists back in Arizona, and we were looking at cadaver sections, and there was these little fatty collections. And I asked them, what were they? I thought they were diverticulum, and it turned out to be these epiloic appendages. The story goes that early man, Neanderthals, okay, ate whatever they could in terms of what they found in the land, and oftentimes they had to resort to eating cellulose, like in branches and bark and things like that, which prevent starvation, they thought anyway. Early man used to have a organism within these little sac-like structures along the periphery of the large intestine, which basically were symbiotic structures or organisms. What they would do is these little organisms, when they sensed cellulose would come out, they would digest the cellulose, producing a little bit of glucose. So the organism itself would sustain itself with the cellulose, the wood product, and man would get a little glucose out of the deal. So man was able to eat wood. I mean, if you ate a pencil right now, you're not going to get any nutritional value from it. But what happened over, true enough, if you decide to eat a pencil, what happened is as man evolved, they didn't have to eat wood, they were able to eat livestock and grains and, granola, things like that. The little characters that lived in these little epiloic sacs died because there wasn't any cellulose in their diet. And what became of the sac-like structures, now I'm going on with what this anatomist told me, I hope he's not lying because I've told this story like 30 years, is that they become fatty collections they call epiloic appendages. And it happened during the epiloic era. When these, do you like that story? You buying it?
No.
I'm buying it. I bought it for 30 years. I can't give it up now from that perspective. Anyway, that's why they call them epiloic appendages. So if you ever have a chance to look at a cadaver, they're pretty cool from that perspective. Questions for me? All right, I have a few minutes left. I'm going to take you through a process next Thursday. Keep in mind, on next Tuesday, I'm going to be walking you through landmarks, and we'll have some other handouts for you. But let me kind of take you through a journey of the abdomen real quick and kind of point out some of the major landmarks. What we haven't covered yet is going to be the muscles and other soft tissues. But I'm